At least somebody read that paper, Mike. Thank you for going over the lighter baseball thing. I think it's actually pretty relevant, so I'm glad you brought it up. So same disclosure side, you've seen it a bunch of times. If you want a reference for this, this is a good reference for this. So Pete, Dr. Romeo wrote this paper. This is a really good reference for upper extremity injuries in skeletally immature overhead athletes. So this is just in the slides so you have it. So we're going to talk a little bit about growth plates, talk about little league elbow, talk about medial epicondyle fractures. When you talk about growth plates, you have to understand the order of growth plates, how they appear and how they close. And it's different in males and females. So if we're talking about males, generally, this is the mnemonic that we have. Everybody who's been through orthopedic surgery residency knows the mnemonic cry-toe because that's when the growth plates start to appear, and you could see their dates here. This shows you when they appear versus when they close, okay? So appearing, closing, male versus female, and again, when they fuse, the cry-toe, so the opposite of cry-toe. And you can see what we're talking about usually is the medial epicondyle, the internal epicondyle, so it's the third growth plate to close here, okay? It appears last and closes third. So if you're treating somebody and their capitellar growth plate is closed, but their medial epicondyle is open, that's pretty normal. If you're treating them and their lateral epicondyle is closed, but their medial epicondyle growth plate is open, that's a problem. That means that's delayed closure of that growth plate, okay? When you take a look here, this is just some studies going over some imaging because we've talked about this a little bit today. I just wanted to bring your attention to kind of imaging in younger players. We've talked about imaging in people coming into the league. This is just an imaging study that was done in asymptomatic kids, 10 to 13 years old in California, preseason MRIs on their elbows, no elbow pain, no pain on exam. They found that 35% of their players had some positive MRI findings. So some have edema within their medial epicondyle. They didn't have any symptoms, but they had some swelling there, which can be seen obviously in patients that are normal and asymptomatic. Some had some fragmentation and some other things, but I just want to draw your attention to sometimes some swelling in the medial epicondyle can actually be normal in these kids. They may not necessarily have pain with that. And when you look at the kids that went on to have pain in this, obviously year-round playing, higher volume workload was associated with higher pain in these players. So let's talk about little league elbow. What is it? Who suffers from it? How do we treat it? So it's an inflammation of the growth plate, the medial epicondyle growth plate, right? That big bump on the inside of your elbow that has a large growth plate. It has to fuse. It's the third one to close in the elbow, right? If it stays open, it can get inflamed. And in kids, since their growth plate is not closed, that's the weak point of the inside of their elbow. In a skeletally mature person, the weak point is the ligament. That's why UCL tears happen. In kids, the weak point is the growth plate. So if something's going to get hurt in kids, whether it's little league shoulder, little league elbow, that's the thing that tends to get hurt, okay? And it's usually just repetitive micro trauma to the growth plate that causes it to get inflamed. In little league elbow, you just want to shut them down. Just have them stop throwing. They can still hit if it doesn't cause them pain. You stop throwing. You work on their other things that are causing them to have too much stress on the elbow. All the stuff we've talked about over the last day and a half, increasing their shoulder range of motion, getting their hip to trunk separation better, getting their core stability better, working on their hip rotation. All those things are important to try to minimize the amount of stress that their elbow sees. So they see in the office, you shut them down for 4 to 6 weeks. You start them in physical therapy, you bring them back, you re-examine them, make sure their elbow doesn't hurt, get some new x-rays if you want. If they feel good, let them start a return to throwing progression. If they still hurt when you examine them, do not let them go back to throwing because if they hurt on your exam in the office, they're going to hurt when they go back to throw. So they have to be out of throwing until they're asymptomatic. This is a kid that came in, had some pain on the inside of his elbow after throwing, no neurologic symptoms. Only thing that hurt him was throwing. Exam, you can see that the most important finding on this exam for him is that his total arc of motion, his shoulder was pretty crummy, right? And we see this in kids as they've gone through a growth spurt. Their total arc of motion starts to go down unless they're a really loose kid. And so that was his main problem leading to having some medial epicondyle apophysitis in this kid. You can see his x-rays here. And when I get x-rays on kids, I always get a contralateral x-ray. I'm not a pediatric orthopedic surgeon. I'm not an expert on growth plates in the elbow. So if I have their hurt side and I take a look at their non-hurting side, then I can compare to see if there's a difference. So on the left side of the screen, there is his injured or hurting elbow. On the right side is the elbow that's normal. And you can see those growth plates look pretty similar. So we're not worried about that growth plate widening at all. Sometimes in these, you'll see the growth plate start to widen, and then we start to get into that kind of fracture category. So his x-ray looked fine. We treated him symptomatically. Once he was asymptomatic, let him go back to throwing. He did fine. Different kid comes in. 2 weeks of elbow pain after an elbow injury while he was throwing, okay? Never felt a pop in his elbow. Sometimes these kids will come in, they say they felt a pop. He did not. Saw another physician, had some x-rays, had a CT scan. So if you take a look at his elbow here, left elbow is the elbow that hurts, or left side is the elbow that hurts, right side is the one that doesn't. You can see there is some difference in the amount of widening at that growth plate there. It's not to that 5 millimeters that we tend to talk about in throwers, which is when we tend to fix this. So if the widening is less than 5 millimeters, meaning the growth plate's not pulled away more than 5 millimeters in a thrower, we tend to not fix these. If it's a non-thrower, we usually use a little bit more, 7 to 10 millimeters as our cutoff. But in a thrower, we want it to be separated more than 5 millimeters before we start talking about fixing this. But you can see there's a clear side-to-side difference there. He had a CAT scan already before he came to see me. I would not have got a CAT scan on this, but you can see on the CAT scan, that doesn't look too bad. Okay, that's pretty well aligned. So what do? Same thing as before. We shut him down, re-examined him. He felt good on the re-exam, let him go back to throwing. He did fine. Got some follow-up x-rays on him because he was a little bit wide when I saw him, and you can actually see a little bit of calluses starting to form in there. Once you take stress off of this growth plate, it will tend to heal in a healthy kid when it's not pulled off too much. So clearly you can see that this is healing. He got back to playing, no issues. This is the different one. This is when we get into the medial epicondyle fractures, or that more than 5 millimeters of displacement. And this can happen from throwing. It can happen from an elbow dislocation, which is most commonly what we see this in, but it can certainly happen in our throwers. This kid was throwing. He felt a pop. He comes in, had a splint on because he went to the ER, and they tend to put them in splints when they come to see you. Took everything off, had a lot of pain on the inside of his elbow, some bruising and swelling, and he comes in with this x-ray, right? This is very different. You can see that growth plate's pulled off and pulled down. And that's usually what happens with this because the flexor pronator is attached to that, right? You heard a lot about the flexor pronator over the last day and a half. When the growth plate is kind of ripped off, it pulls that piece of bone distal because the flexor pronator is still attached down here. So there's a distal pull to that piece of bone, and that's what happens. It pulls down. So you can see very different from the other kids that we saw. This was his contralateral elbow. Growth plate's almost closed on that side. So this is a problem in a thrower or non-thrower. That's the different side to side. I think you can appreciate that in that piece of bone, that little semicircle half moon should be pulled up much more. And so in this person, this is you should fix this. You can talk to them about conservative treatment, and in a non-thrower, if they really didn't want surgery, you might be able to get away with it. If this kid wants to go back to throwing, this is something that we need to fix, okay? And the way we fix this is we usually fix it with one screw that goes right across the fracture site. So the way I do this is I position them lateral. You can do this supine, but I put them lateral, and then you make an incision kind of over the fracture side of the medial epicondyle. You get the nerve out of your way. So I actually find the nerve. I put a little Bennett retractor that brings the nerve back into the olecranon fossa. So I put the Bennett hooks in the fossa and pulls the nerve away from me. Then I dissect out my piece. I put a fiber wire stitch in it to control it. I reduce it. I pin it in place with a K-wire in a spot that I don't want my screw to go. And then I'll put my screw right down the pipe. With this one, you have to make sure that you are not going to get into the olecranon fossa with your screw trajectory, because obviously that'll cause a problem with them getting into extension. You want to try to aim up the column, as George told you before, when you're doing UCL repairs. We use a cannulated drill, and then we use a full-length screw. You need to make sure when you're drilling for the cannulated drill, you drill basically the full length of your screw, because if you don't, there can be some bone islands in these kids that are very hard to get past. I've broken a screw one time putting it in as I was twisting it because I didn't drill far enough with the cannulated drill, and part of the screw broke off. So I had to take it apart, take the screw out, put a new screw in, but just make sure you drill far enough with the drill while you're doing this. Usually we use a washer just to help dissipate the stress, because it's a very small piece of bone. Even though it looks big on the x-rays, that piece of bone is very small. So you don't want to crush that or compress that. So I usually use a washer on this. Sometimes it bothers them. You have to tell them it's going to bother you. Some of them want it out. Some of them don't. If they want it out, you go in and take it out. It's no big deal, but you have to shut them down for throwing when you take it out. This is him in 3 months. Clearly it's fused. He has no pain. He went back to throwing, no issues. This is not something that's widely published or studied. You saw our paper before on the hit stat in professional baseball players with epicondyle fractures. But this is basically looking at youth players with epicondyle fractures. And this is a paper that was done by Daryl Oshbar and Pete Chalmers. And basically they looked at players that came in with, growth plate injuries. So whether it was a fracture or not, they based it on how much separation there was. So if the players had less than 5 millimeters of displacement, they got treated conservatively. More than 5 millimeters of displacement, they got surgery. Both groups did really well. Average return to sport was about 7 months for this. Obviously, non-op went back faster than operative treatment, but most of these kids did very well. So little league elbow, extremely common. Shut them down, wait till they're pain-free, let them go back and play. Epicondyle fractures, when there's more than 5 millimeters displacement, fix these, one cannulated screw, washer, not hard to do.